All right, we're totally skipping the usual intros today because we need to jump straight into a massive, life-threatening clinical scenario, obstetric thrombophilias. When you're managing high-stakes cases on the wards or facing an integrative multi-step board simulation, understanding the looming hypercoagulable threat to both the mother and the fetus is absolutely non-negotiable. We're looking at conditions that silently weaponize the coagulation cascade, literally turning a routine pregnancy into a devastating vascular event. So let's immediately lock into the underlying pathology.
Module 1. The inherited resistance. Let's look at the foundational pathology of these genetic hypercoagulable states.
Okay, let's dive into this. Factor V Leiden isn't just some random anomaly. It's the most common inherited thrombophilia you're ever going to encounter. It's a strictly autosomal dominant point mutation that completely alters the precise cleavage site on the Factor V protein. To really understand why this is so dangerous, we need to look at how this totally derails the body's natural braking system.
Under normal physiologic conditions, activated protein C, or APC, acts as the master brake on your coagulation cascade. It attempts to cleave and degrade Factor V to halt clot formation. But here's the critical failure. The mutated Factor V Leiden strictly resists this degradation. Because that cleavage site is physically altered, the brake just completely fails to engage. This leads directly to unchecked runaway thrombin generation, plunging your patient into a massive hypercoagulable state. This biochemical resistance translates into a massive, non-negotiable clinical threat. For the obstetric patient, this means a drastically elevated risk for deep vein thrombosis and lethal pulmonary embolism. But uniquely, it also presents a severe threat to the fetus. That unchecked thrombin generation leads to placental microthromboses, literally choking off the vascular supply to the fetus, which results in recurrent pregnancy loss. You absolutely must recognize this mechanism instantly when evaluating obstetric complications. Module 2. The acquired autoantibody. We're stepping away from genetics now and moving into the unpredictable realm of acquired immune conditions.
This is the antiphospholipid syndrome, or APS, immunologic strike. Unlike Factor V Leiden, APS is an acquired autoimmune disorder. It's driven strictly by a highly specific profile of rogue antibodies. You must know these three: the lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. These autoantibodies circulate in the blood, aggressively targeting phospholipid-binding proteins and directly provoking intense vascular thrombosis. Now, what's really interesting about this slide is the diagnostic paradox. When you draw blood and run a basic coagulation panel in the lab, in vitro, the lupus anticoagulant actually binds the phospholipids in the test tube, giving you a markedly prolonged PTT. And if you attempt a mixing study with normal plasma, it completely fails to correct, because that antibody is still right there blocking the reaction. Yet inside the patient's body, in vivo, this exact same antibody causes massive clinical thrombosis. It looks like a bleeding disorder on paper, but it acts as a deadly clotting disorder in the patient.
And here is a masked diagnostic trap that will absolutely catch you off guard if you aren't paying attention. Those anticardiolipin antibodies we mentioned? Well, test examiners absolutely love to use them to trigger a false positive VDRL or RPR screening test for syphilis. They will hand you a positive syphilis screen just hoping to bait you into a completely incorrect infectious disease workup. You must confirm with a highly specific FTABS test. In APS, that confirmatory FTABS will come back completely negative. Seriously, do not fall for the false positive trap.
Module 3. The prophylactic mandate. Let's move to and see how this builds into the strict clinical protocols required to manage these conditions.
Both severe inherited thrombophilias and acquired APS carry an absolute, non-negotiable risk of fetal demise, which usually strikes in the second trimester or later. For a pregnant patient with confirmed APS and a history of prior miscarriage, there's a clear dual therapy mandate. You must prescribe low molecular weight heparin, specifically enoxaparin, and low-dose aspirin. This dual therapy must be initiated immediately upon confirmation of the pregnancy and continued throughout to prevent those placental microthrombosis.
And this brilliantly illustrates the critical distinctions you need to internalize. Let's look at this clinical variance box. Factor V Leiden is an inherited genetic mutation, whereas APS is acquired and autoimmune. In Factor V Leiden, your baseline coagulation studies are completely normal, and it requires genetic PCR testing for confirmation. But in APS, you see that paradoxically prolonged PTT, you see the false positive RPR trap, and you absolutely mandate specific antibody confirmation. Side by side, their presentations are starkly different, even though they both lead to deadly clots.
The master case. Testing the nuance. It's time to apply this directly to a high-stakes clinical simulation, perfectly calibrated for a 280-plus score.
Here is your patient profile blueprint. Listen carefully to these parameters. We have a 31-year-old female presenting at 10 weeks gestation for her first prenatal visit. She has a history of 2 prior spontaneous abortions at 16 and 18 weeks. You order routine labs. They return a normal PT, but a strikingly prolonged PTT of 55 seconds. Furthermore, she has a positive RPR. You order the confirmatory FT-ABS and it comes back completely negative.
I really need you to pause here and recognize exactly what's happening. Warning, this is a highly engineered diagnostic trap. That prolonged PTT of 55 seconds is heavily tempting you to misdiagnose an intrinsic bleeding disorder. Your brain naturally wants to see a prolonged PTT and jump to hemophilia or von Willebrand disease. But if you take that bait, you will aggressively mismanage a highly hypercoagulable patient, leading to disastrous consequences.
So, the crucial point is how you navigate the option matrix. Let's break down the exhaustive rationale. Option 1, desmopressin, fails because you took the bleeding trap bait, assuming von Willebrand disease. Option 2, factor VIII replacement, is out for the exact same reason. It falsely assumes hemophilia. Option 3, benzathine penicillin, means you were lured in by the false positive RPR, completely ignoring that negative FTABS. Option 4, warfarin, targets hypercoagulation, sure, but it is strictly teratogenic in pregnancy. That leaves option 5, enoxaparin plus aspirin. You successfully map the uncorrected PTT and the false positive RPR directly to the APS mandate.
Which brings us to our final thought. As you review these incredibly complex obstetric presentations, ask yourself, when a paradoxically prolonged PTT and a false positive RPR mask a deadly hypercoagulable state, are you going to fall for the bleeding trap, or will you see through the artifact and execute the prophylactic mandate? Master this nuance, trust your knowledge of the underlying mechanisms, and you will navigate these high-stakes cases flawlessly. Keep studying, stay focused, and I'll catch you in the next explainer.